Welcome back to the Gillett Health Podcast. This is part 2 of our discussion with Jim Lavalle. And among other things, we chat about continuous glucose monitors or CGMs, the future of CGMs. We chat about performance-enhancing drug use and excuses for failed tests. We chat about GLP-1 medications and also liposomal supplements and liposomal medications. So please enjoy the second half of our discussion.
What do you tell athletes that might do high intensity sports or very explosive sports? Say your sprinters, your CrossFitters, your basketball players, your soccer players that they mostly correctly say, I want to have a lot of dietary flexibility. I want to have good amounts of glycogen stores, and I want my performance to improve. Do you track those patients with CGMs, or do you just look at their fasting insulin and glucose, or how do you approach those situations?
I mean, CGMs are interesting, right? Because it's interstitial fluid, right? So you get some semblance of accuracy with it. I mean, where it's really accurate, it's just showing oscillation of glucose, right? Like what's your postprandial event, right? Because we know the most inflammatory thing in your body is postprandial hyperglycemia. And so with athletes, if they wear a CGM and if I'm going to be concerned about it, it's usually in the first month of them learning what affects their glucose oscillation.
Their cold plunge.
Man, that's a whole other, I would love to talk about that sometime. So the point being is, and there's probably some rationale. It's going to be interesting as we look at that. I think there's some rationale to the way cold plunge should be applied, maybe, versus, just, I do them every day. Like we have people, it's funny. I was talking to one of my associates at Lifetime. There's people who are sitting in a cold plunge for 30 minutes. It's like, what are you doing? You're telling your body that you're in the polar ice cap for 30 minutes and you're underwater. It's great. Perfect. So what I tell them is, once again, where is your glucose? Where is your insulin? Where is your A1C? Because we do need glycogen storage. But how do you know you're storing glycogen? Well, the more efficient your glucose is, the better your insulin's regulated. And then let's see your performance matrices. What's your power output? How are you doing? Once again, I've got athletes that need higher carbs. I've got athletes that get by in a more modest carb and they feel like they get better energy when they have a little more fat. Say they're more like 40 fat, 30 protein, 30 carb, right? And there's other ones that need that extra carb and the protein and the fat come down. Well, my dietitians figure that stuff out. I used to do that, but that's, to me, is like pretty straightforward. Mm-hmm. But there's so many things that influence glucose and insulin regulation. So I get more concerned about overtraining, for example. Athletes that are doing CrossFit, that are endurance athletes. I mean, we know that once you train over 30 minutes, you're starting to affect the microbiome. So by default, you're starting to create changes in, glucose metabolism.
Mm-hmm. Yeah. And we're very excited for continuous monitors to also check lactate levels. I think that'll be hugely helpful. We know that ketones are coming soon. Alcohol is coming soon.
Right.
And eventually things like LH.
Right.
And testosterone. So
studies are about to get a lot better because instead of looking at a snapshot, you've got this massive data. Now you've got to rethink things.
Area under the curve for all those, which is going to be hugely helpful. And we know that there's already like urine test strips for progesterone metabolites and estrogen metabolites and things like that. But
salivary,
the continuous monitor is going to be very helpful. You mentioned sodium bicarbonate, and we talked about liposomal delivery the last podcast, but you're a great source of knowledge regarding, how is buccal delivery different from sublingual, or you swallow something orally? Is it hepatically absorbed or lymphatically absorbed, which is the liver and then the lymph system?
Right.
But one question that we've actually gotten quite a bit from athletes watching the Olympics and whatnot is, that maybe they want to take sodium bicarb, but they don't want to buy the brand name one that costs $35 per serving. And, there's slow release bicarb, and things like acetate and even citrate can lead to bicarbonate levels increasing downstream somewhat.
Right.
But that of, is there work in a non-oral bicarbonate supplement, or where do you see as far as like the future of altering bicarbonate levels and or pH buffering lactic acid in athletics?
Sure. Acute or chronic? Like, what do I do every day? Or, hey, I got to do this 5 minutes before my competition.
I'm interested in both, of course.
Okay, I'm going to give you two different answers.
Yeah, people are most interested in acute.
Yes, look, I think that there will be a time where we do. I mean, we've done a lot of research in kind of lipidomics on creating different weighted lipids and their ability to penetrate the skin more deeply and act as a carrier. And so I think that there'll be transdermal, gel, aerosolized, nebulized applications to work at balancing that acid alkaline balance, right? Because, CO2 is related to all that, right? And so things like, and I haven't seen any papers on this, but, looking at inhaled magnesium, which they do for asthma, but looking at, pH, lactic acid, what happens when you use inhaled magnesium? So it would make sense, right? If you're nebulizing mag, it's getting into your bloodstream right away. How quickly is that changing lactate?
Yeah.
It could be pretty interesting, right? I mean, obviously, if you keep your magnesium pull up, you keep your red blood cell mag pull up over above 5.6, they typically will keep an alkaline urine and their lactic acid disposal is much better, right? Maybe if you add something like ribose and on the chronic side. But on the acute side, I think you'll see topical and nebulized deliveries will be something that'll come around. What you could do is you could do a Epsom salt cold plunge right before the competition, maybe, right? 5 minutes before.
Yeah, that's funny.
Yeah, that'd be the Olympic track. You've got the plunges lined up right behind the starting blocks for the sprinters.
I think there's a
but
really
then you'd
popular.
They'd be banned salts because they may have impurities.
Some oxtail salts.
Yeah, you're gonna have to
some
have
trenbolone in it.
WADA testing for your salts.
I think I saw a YouTube video where the thumbnail is how trainers drug their athlete or how trainers get substances in their athletes. And it was someone rubbing a cream on someone's calf, presumably with SARMs or some sort of,
right.
Or maybe doing testosterone or something like that.
Yeah.
But yeah, we have discussed this on the podcast before, whether intentional or not. People are transdermally absorbing performance-enhancing substances.
Yes, even SARMs. There was the case. We were playing a game. I was like, hey, Kyle, guess if this is a real doping excuse or a made-up one. And it turned out to be real, but sharing running sleeves. So one guy on the team was doping with SARMs through the sweat, so it's leaving his body. The other guy borrowed his sleeves, allegedly, or that's the excuse. And then he found it was much lower concentrations, but the same drug that this guy on the team was taking was found in athlete B, who also tested positive.
So they both tested positive.
And the running sleeve
I'm going to give
positive.
you even a better story.
All 11 samples of the running sleeve had SARM in it.
They tested the sleeve and there it is.
So I had a guy in the NFL that had come to me for several years into our clinic, and he had needed drug testing just because he was on a medication. So they have a policy for certain medications. You have to have testing. And he survived 71 tests. Stopped coming to our facility. I get a call. He goes, I got suspended. They found GHRP6 in me. And I went, okay. He goes, I need you to talk to the NFL Players Association. No, because they're going to think I'm the one that gave you it. It's like, no, I'm not going to talk to them. Yeah. I mean, he goes, well, couldn't you tell them that I got it by eating a hamburger in Mexico?
Oh.
This is a real story.
Yeah.
I was like, urban myth, by the way.
Yeah.
I searched right away. I was like, I can't find anything about GHRP6 in Mexican hamburger. So yeah, but it's look, there's a lot of creative ways athletes or their coaches will look to getting an edge. Another real difficult area, because why a lot of times you look at Olympians, and because we ban, I think there's a lot of things that are banned that actually are pretty good for for someone, like healthy, actually. Like we
BPC
talked about
157. Yeah.
BPC 157 is an ideal thing. TA1 to keep their immune system on track. I mean, 10% of the Olympians will end up getting sick. You know, leading front runners, they get the qualifications. They end up getting
Noah Lyles
sick.
He got sick.
Yeah, they get sick and they can't make it because we're not keeping their immune system optimized. I think, you know, a peptide like, you know, thymosin alpha-1 that's got a fair amount of data behind it. You know, there's monographs that are published on it, review papers published on it in humans. I just think that, wow, we're missing the boat on, you know, you think about it. If say your 4-year degree program, you're going up to get your diploma, right? And the professor goes, not going to give it to you. That's kind of, when you think of an Olympian, it's been training their heart out.
Yeah.
Everything's been going to that. And we don't allow kind of any countermeasures to help them stay healthy that I think are pretty significant. Yeah, they can eat better, and yeah, they can eat better, but they're pushing their bodies to a way bigger extreme. You know, and people always ask me about it all the time, and I'm like, well, you know how I want to train, you know, even harder. Were you getting paid? So what's healthy to train? And I like training hard, don't get me wrong, but I also know that I'm not getting paid to train. So pushing yourself really hard. And that's why you see these rates of injury and these things are going up, because their bodies are put at these very extreme tolerance points where things can get on the edge and break.
It's about what's the trade-off is the question you're asking. You know, if you're putting in more and more and more volume, eventually it's going to be diminishing and you're going to set yourself back. And then, you know, you have the total other end of the spectrum from the Olympics now with the enhanced games. You've heard of this movement? So then what's, you know, the trade-off there is going to be also on the health side.
Yep. How much health do you give up?
Yeah.
And I suppose some organizations like strongman competitions already do that. So it's not like it's an unprecedented thing.
Sure.
But I believe the definition of a professional athlete is you make more than 50% of your money, you know, your livelihood doing that sport. One thing I've wondered is what percentage of professional athletes do you think have ever intentionally or unintentionally taken a banned performance-enhancing substance? So how fair is sport really? Because I think that number is pretty high.
I don't have a number I could shoot at it, but I would say it's probably either unintentional or intentional. You're probably at over 50% of the of the population, because like the gentleman that I was talking about, he had no idea that he went to a new clinic, they put it in an IV, you know.
GHRP6 and a
just
IV
do an IV
therapy?
push through a bag, right? So they just did it, you know, while it was there. Oh yeah, I mean, they were
interesting
things.
Put everything in an IV. Combine it with some glutathione, see what happens. Don't do that.
You don't combine anything with glutathione.
Don't do that. That was a sarcasm.
Glutathione is by itself.
Button.
Sarcasm button. Yeah. Don't do. No, I mean, so I think unintentional or intentional is probably it's fairly significant. I think it's also because they get pushed. I mean, it was baseball, right? When we talked about baseball and a lot of you know, that era of, you know, baseball players that were using, you know, different kind of, you know, androgenic substances. Well, they're beat to a pulp. They feel bad. Their sex drive is probably down. They're not recovering. They're being injured more, and you know, they don't have a number that they can hit. You know, they're not allowed to replace, and so you know, they kind of reached out, and then all of a sudden of course that wall came tumbling down. And I just think it's more about it. Things have to change. And the enhanced games is going to be interesting because, you know, when I talk to certain people that, you know, I've had to work on over the years that are enhanced, it's like, wow, that is enhancement. The amount that of chemicals they're putting in their body is just staggering.
Yeah, they're an underserved group. And when they retire, there is a lot of issues. Right. This is a conversation we had with Derek when we helped him start his Merrick Health Clinic more than 4 years ago. Is these people are often uninsured or underinsured. They've perhaps never seen a physician before. And the slippery slope for good is they get into a telemedicine clinic and saw one of us and they go to another physician and get an in-person exam, and they check off a lot of health items that they wouldn't have seen otherwise if not for these telemed clinics.
What do you think are the big things that you see when people are in that, PED area? What shifts do you see? I know what I've seen in their chemistry, but what do you guys look at and see and go, oh yeah, this is messy?
Yeah, it's interesting. It depends on the substance and the dose. I mean, probably one of the more frequent encounters would be the young guys, 19 years old, that get their hands on these SARMs that are over the counter.
Right.
And then they're like a month later, like, yeah, I stopped and now like nothing works. I feel like crap. And you're looking and it's like, wow, they're still suppressed by this thing and they're not taking it. So then you have to wake up the pituitary, and a lot of, like, you go to a GP, and we actually wrote a paper on this. It's like, for these guys that do this and maybe they didn't even know what they're taking, they go to their general practitioner, they're going to say, I guess you got to go on testosterone now, or,
right.
Just sort of anything can happen. So that's the example that sticks with me, because this is someone that's like in their best health they'll probably be in. You kind of, when you're in your teens and your 20s, like, you're in generally good health.
Right.
And they've like gotten themselves into this situation, and they just need someone to like take the history, know kind of a little bit about these things, and then get them on a plan and be like, hey, let's get you back on track.
Yeah, I think it's interesting on SARMs because in general, SARMs really aren't approved for human use, but yeah, you can buy them.
Yeah, same for a lot of medications and peptides.
Yeah, yeah, but the SARMs, though, I mean, you've had pretty strong statements come out from, like, the Council for Responsible Nutrition, FDA, and I happen to think that SARMs could have value if they're used appropriately and the ones that are safest, like LGD 4033, for example, has got some pretty decent,
they have a phase 2.
They've studied Ligandrol
coming out.
Yeah.
Yep.
Yeah, I think there's a little bit there.
Yeah. And the doses are way different. So you look at those; they're using like single-digit doses, and you may go on Reddit and you see some guy taking 50 milligrams of that.
Yeah, and it's like the studies were at 0.3, 1, and 3 milligrams, right? And they're starting at 10.
Yeah.
I think you hit probably an epidemic that's brewing, because you look at how many sites where SARMs are available, and for those listening, selective androgen receptor modifiers, SARMs, and they double-digit testosterones on these guys, and now women are using them in the physique competitions, right? So you got a lot of women that are doing physique that they're using them as well, and so I that's a big one. I think that the other one that I saw a lot of is just, when people are doing a lot of anabolics, a lot of kind of the nandrolones, testosterone, the various, primobolan, you name it, right? Their lipid profiles get crazy, and their liver enzymes obviously get crazy because the doses that they're doing are so significant, and then you have to walk them back from that ledge after they get through that. So it's a whatever career it is where they're doing those kind of things.
Very common to see secondary erythrocytosis with concurrent deficient ferritin, iron deficient levels from over phlebotomizing.
Yep.
Also not uncommon, especially when they've been using for years, to see both dilated or hypertrophic cardiomyopathy. So too thick of heart, or basically too dilated of heart. Yeah. So there's certainly a lot of things.
A lazy left ventricle.
Yeah. People can check out our open access article. I believe it's Social Trends in PED and SARM Use, published in the Curious Journal from a couple of years ago.
Yeah, we'll link that in the description for people to check out.
That's an important one.
Yeah.
That's great you guys are on top of that, because I think it's going to be an epidemic. I mean, you look, out west, California, it's, people are just, hey man, I'm on this because it's surfing season and I want to shred a little bit, and they're throwing off their HPAG, right? Hypothalamus pituitary adrenal gonadal axis by doing that. And sometimes it's not the quickest thing to restore, right? Just to get the pituitary firing, in clomiphene or something like that. It takes a while to massage them back into, being an appropriate 21-year-old again.
Speaking of epidemics, we asked the same question to a top urologist, a reproductive infertility urologist, Dr. Fantis, and he seemed to agree with us that there is a big epidemic. I don't know if you want to give a specific number. We've kind of guessed our number, but the number of people who have taken, a number of adults, if you can do males and females combined or separately, that have taken some sort of hormone. It could be a pro hormone from GNC when they are doing their high school football, whatever. It could be an oral contraceptive pill. It could be, some Clomid during fertility. But what percentage do you think have ever tried some sort of hormone?
If you don't include environmental estrogens, so endocrine mimicking, compounds that are in the environment, or, shampoos that we all use. So we don't include those, and it's just things you've taken. I'd say it's 90%.
Wow.
Because look how many women are put on oral contraceptives right away. So you're going to include
90% of women.
A lot of women. And then on men, there's this increasing amount. If we include SARMs,
SARMs are included.
If they're included.
And pro-hormones.
I think you've got a big population. And 90 might be a little strong, but it's definitely over 50% of the U.S. population is there. It's in that spot that it's a lot more people than we think about. And, for me, I've been on my soapbox about oral contraceptives. I understand their value. I get it. Nobody explains the risks to young women most of the time, because there is risk.
Or the difference in a levonorgestrel and a drospirenone.
Yeah,
Very different.
Most clinicians don't know, and that's why they can take our Hormones 101 CME course and get CME credit for it. But
that's great.
That's one of our favorite cognitive dissonances to bring up is they go to their doctor and maybe their mom's been there and asked for some bioidentical HRT, and they're not comfortable prescribing bioidentical HRT because they don't know about it, but somehow they're comfortable prescribing synthetic HRT, which is what hormonal contraceptive is.
Especially with the synthetic progestins, right? The medroxyprogesterones, which is where the real big bad risks are at, is in those synthetic progestins versus bioidentical progesterone, right? Which you can still get into trouble having too much progesterone, right? Some women will hold weight, and but that's a lot different than the side effect profile that occurred that they discovered in the Women's Health Initiative, right? And that when they looked at these synthetics, it's interesting. As I told you guys, when I started out, I was working with an OB-GYN. She wrote The Idiot's Guide to Menopause. Her name was Maureen Pelletier, MD, OB-GYN. And we were into bioidentical hormones in 1988. And we worked at Good Sam Hospital. So we were at Good Sam, and we had started a integrative clinic at the hospital, actually. And she really was in front of the curve on it, showing the value of bioidentical hormones and really working with men and women on bioidentical hormones. And it was amazing how everybody lumps it all together. It's hormones. And therefore, if a study comes out and it's bad, it's all hormones are bad.
Yeah. And
not understanding just how vital they are, right? I mean, you think of a woman over the age of 60, if she has low testosterone, probably needs a little help there. Mm-hmm. Estradiol in women when they're menopausal or perimenopausal and they're having, vaginal dryness, or they're having urinary incontinency, or they're having mood changes, or the big one, which I still think nobody stinking talks about enough, bone loss for both men and women. Mm-hmm. But, to me, another one, it's a biggie, and hormones are a really important component to that. It's I think a lot of people have tried them, and not a lot of people have another area in this space, right? There's a lot of variability in the kind of hormones that people are taking, even within the bioidentical hormone space, because there's no standardization of what the bases are.
Yeah, it's interesting to see how uncommon some hormone preparations are, like estradiol cypionate, a commercial product, compared to estradiol valerate,
right?
Which is much harder to get to a nice, even, steady state level. And a lot of people don't even like injectable estradiol at all.
Right.
And same thing with testosterone.
Right.
Testosterone undecanoate is not popular at all.
Right.
The decanoate and sustanon is popular in some countries, but not in the United States.
Yeah,
but
can't get that here.
I mean, even among things that are commercially approved, decanoate and undecanoate bound to testosterone or even estradiol seem like a great option for many that are completely dialed in. But how have we come up with the esters that we choose when we do use bioidenticals?
Yeah, I mean, I think I'll go once again. I think right now we're just really learning about circadian rhythm of hormones, and I guess I'm more of the opinion of the more someone gets dialed in, it's probably going to change the, whether you're using a decanoate, which has a little bit longer acting effect, actually, if you look at nandrolone, for example. Right.
Yeah, it's interesting that nandrolone is it's okay to bind that to decanoate, but just having a testosterone decanoate product is not okay. And I find it interesting that not even a small pharma. Exactly. Yeah, there's a lot of small pharma companies that have great commercial products, subcutaneous testosterone, lymphatically absorbed testosterone, et cetera. But none of them has tried to mimic the rhythm for either males or females for adding some sort of nasal or a troche or lymphatically absorbed testosterone capsule on top of a basal testosterone. And maybe that's a little too complicated for a lot of people, but if it was popularized and people liked it, then I don't think it's too complicated.
Yeah, I think to me, it's like having a baseline and then having pulsatile rhythm of your hormones is really important. It's part of that starts with what we said about the 3 most important things to do. Diet, right? Exercising, the sleep, the diurnal patterning of sleep, to keep that master slave clock intact that regulates all your hormones during the course of the day, right? So, you've got to deal with that. So I'm a big advocate for pulse dosing morning and afternoon on testosterone to achieve that circadian timing, because I think it's the way our body works. And then having baseline is a good idea because we've got people that have such a poor baseline due to our modern world, right? Like everything that they're doing kind of suppresses that. And so that's actually a great idea in utilizing a more immediate release with a quicker half-life, like intranasal, like a troche, like a liposomal tablet of a testosterone, where you're getting a 4 to 6 hour effect and then it's gone, versus say a baseline pellet or a every 2 or 3 day injection subcutaneously of a cypionate, or if you want to use tri-test, right, propionate, cypionate, entonate, right?
I've heard this question answered differently. For the commercially prepared oral lymphatically absorbed testosterone product, are you going to get better absorption with fat as you take it, or can you take it completely fasted and it's just as good?
It's going to work just as good because it's designed to be absorbed through the micelles. So, I mean, if it's a lipid, it's going to go. It's going to work. Won't matter.
So you do not have to take it with any fat?
No. Not if it's designed to be absorbed as a lymphatic or micellar absorption. It's designed to be absorbed that way.
Yeah, supposedly, but doesn't the lymph absorb a lot more when it detects the presence of fat in the gut?
But if there's fat in the formulation, if it's a liposome, for example, or some sort of a fat that it identifies, it's going to do it anyway. You're asking, is it required? It's easy.
It doesn't seem required, but to me, since there's less than 1 gram of fat, there's got to be some dose maximum when you have a threshold of fat in the gut that's detected to when you absorb the largest amount. But yeah, I suppose it's not required. So as long as the patient checks their level, obviously you can dose them accordingly.
Yeah, well, you're gonna check their levels, and that would assume also that it's not a mixed meal.
Yeah. Part of it is for patients that are on a diurnal rhythm of bioidentical testosterone replacement. Let's say they're on a long-acting ester as their base, and then they're on a single capsule of oral lymphatically absorbed testosterone. All of the different companies have cash pay products. There's 3 main ones, and then there's compounded ones too. But anyway, that's the cash pay price is still relatively high. So a lot of patients want to get their kind of biggest bang for the buck when they do take it. So that's kind of where the question came from a clinical standpoint. I know that.
I mean, I actually had dinner with the lead pharmacologist, urologist that did the studies on one of those compounds. They didn't seem to think it made that big of a difference on their trial that, hey, that was required that they did it with food or without. Their main thing was timing.
It'd be nice if they posted it in the supplementary data.
It'd be nice if they posted drug-induced nutrient depletions in their supplementary data, but it's hard to do that when they don't even study it. So agreed.
Yeah,
totally agree.
I suppose from the patient standpoint that asks us questions like this, they're wondering, well, to the pharmaceutical company, it's not a big deal because if you only absorb 70% as much with a lower fat load, you don't need it. But then your physician just prescribes more when you're due for your refill because you get your peak level 3 to 4 hours later. And then you say, well, you only made it to 600 total. So let's increase your dose. But the problem is that often if that's taking 2 capsules, that doubles the amount that the patient ends up paying.
Well, yeah, and then they usually are taking something in the afternoon too. So if they're following the same habit, they could be taking more, cost more, all those good things.
Mm-hmm.
But I would hope that there's some consistency, right? What I try to do is get across to people, well, if you're going to, maybe the only way they can do it is taking it with a meal because that's when they're going to remember it.
That does help.
And then there's people that say, I don't like to eat breakfast. And then unless it's a requirement, it's like, all right, well, let's see how your numbers are.
Mm-hmm.
Yeah, well, maybe you better try eating that with, some avocado toast in the morning or something like that. But it would be GMO-free, sourdough, gluten-free sourdough toast. And it wouldn't be toasted so high that it would create any kind of volatile compounds that might induce cancer. So there's a special toaster now for that.
It goes in your cold plunge on the side there.
To continue on the theme with medication delivery.
Sure.
A lot of people ask about, what are the benefits of certain troche delivery or rapid dissolve tablet? Because some people hear on, large podcasts, bioidentical hormones should always be troches and tablets. And then some people hear, well, they don't have to be troches and tablets. What do you say to that question?
I hardly do any other than, I guess, progesterone is troches and tablets. I mean, usually when women come in and they've got estrogen in any kind of troche or tablet, which has become pretty popularized now, I see a lot of abnormal metabolites. So I'm not a big fan of it in that way. For me, delivery is more about, it's about how is that N of 1, how is the patient's numbers? I've got men, which I would never believe, do great on foam testosterones. Like I can't stand topical testosterones. I just see there's a ton of aromatization that takes place. It's very difficult to get them down. But then every once in a while, a man comes in, his numbers are great, he feels great. And what am I going to tell him? Never do a testosterone topical, right?
Yeah.
For him, it worked. In general, troches are still going to go through first pass effect for the most part, unless they have some sort of lymphatic absorption that's involved in them that they're going to avoid first pass effect. Why do we worry about first pass effect? Metabolism of the active drug product. Where's the estrogen going? What's it turning into? What's happening with that testosterone? What's the base when we say a troche? Well, there's variability in that. How is that going to be, playing a role in it? I would say that before I got into really appreciating nasal, liposomal delivery orally, tableted deliveries, I was always more of a fan for testosterone of sub-Q because it was easy to twice a week get a man in a pretty good number right? Or a woman, right? Either
Yeah.
one. You could get them at a pretty good number fairly easily with not a lot of pain. They don't have to think about a big IM needle, which is creating big peaks and troughs in them. And,
Definitely.
you know, right? So I wasn't, I'm still not on the, you know, the trochee train for all hormones.
Yeah. I think sub-Q twice a week, like you said, it's leaps and bounds ahead of the 2-week roller coaster that used to be standard. And that's studies still showed benefits with that.
Yeah.
So that's sort of what I'm thinking. Well, what if we redid those now and had people with more stable levels? You know, presumably you would see lower risks, more benefits.
Right.
And I know we've asked you to throw a lot of numbers out there, but with the concept of like liposomal,
which I have no data on.
well, that's why people wonder. They want to ask an expert that has seen a lot of cases.
I've done that.
It is a lot of speculation, and I will post a few links to. I want to call it MEPS data, but it's not MEPS data. But the government does have a database of prescribing trends, and I'll link it in the description as well.
Oh, cool.
With the liposomal, right? That's sort of a buzzword, or has become. Yeah. I mean, if you're just guessing, so I see that all over the place. You know, liposomal vitamin C, liposomal glutathione. What percent of those products? Because I know you know this space, and like there are some good liposomal formulations, and there are some that are just putting a sticker on there. But I mean, what percent of those are reliable? I mean, what percent would you trust if you're just going over the counter and you see something liposomal that it's actually being delivered in a more superior manner?
Well, I mean, depending on when it is from the date of manufacturing, if you're buying it in the first 30 to 60 days of manufacturing, probably 70% of them are going to deliver what they say they're going to. The problem is on liquid liposomes in general, and I'm not going to say this universally, but in general, liposomal liquids agglomerate, meaning that you've got these basically electrostatic charges that keep, you know, small molecules apart, and that allows you to absorb more of something when it's in a liposome, right? But then what happens over time is that electrical attraction, the magnetism comes back, and you start to build really big molecules. So you go from particles of less than 100 nanometers, which cross the blood-brain barrier, cross your gut, you know, they're readily absorbed into your cell, to a 3,000, you know, nanometer molecule. It doesn't do anything. And, you know, just so you know, so from that standpoint, as for me, as liposomes age, and this is papers that are on I mean, you can look this stuff up. These are concerns from FDA, and even from the other side of the, you know, I'd say the aisle, right? They have big concerns on liposomes about stability. And there's multiple papers they've published related to that. I'd say, you know, obviously with being involved with solid state liposomes, when we can show that they stay in, you know, less than 100 nanometers, basically on the bell curve of looking at microscopy and fluoroscopy and seeing that they stay small, that's at least the first step towards showing stability over a 2-year period, that they don't agglomerate when they're put in that solid state. So I think that's interesting. You know, I think just particle size in general is a big problem, because I remember I was doing a study with these folks had basically, it looked like an inverted rocket engine, and they would you could dump rocks in it and it would come out powder because it was microgranulating it under sound. So there wasn't any heat, which can distort things, right? Can distort molecules, can create all sorts of, you know, matrix.
You're trying to make a
matrix
polyphenol
changes.
Supplement, and you're destroying your polyphenols in the process.
Yeah, exactly. And you know, this was first developed to try to get gold out of, you know, low gold yield rocks, right? But then they started doing it with nutrients, and what we found was, you start looking at electron micrographs of even certain drugs, just commercially available drugs, and the shards are too big to be absorbed. So this whole aspect, I think, of bioavailability and absorption of nutrients is still got to continue to be kind of, you know, uncovered. Liposomes being one of them, where, you know, is it stable 6 months from now? Do you guarantee, you may have a bunch of vitamin C in there, but it might be wrapped up in a big old molecule now that, you know, can't be absorbed, right? So the vitamin C content tests out, but, you know, is it absorbable?
Sure.
So I think it's an issue.
This same issue extrapolates to exosomes, whether they're adipocyte or mesenchymal derived as well, I'd assume.
Yeah, exactly. Yeah, no, I mean, I think it's, in general, I always tell people it's not how much drug you take, it's how well it gets utilized.
Mm-hmm.
And that utilization depends on, are my receptors functioning? You talked about the SSRIs. One of the big problems I have with that, going back earlier, is that if they're reuptake inhibitors, that means that whatever neurotransmitter, whether it's noradrenaline or serotonin, is continuing to hit that receptor. You start to get changes in receptor conformation. The receptor starts getting banged up. Doesn't look the same. That same thing applies. Is, do you have blockade of a receptor? Things like pesticides or like a toxic metal that displaces a nutrient like calcium or magnesium or copper from an enzyme, starts to change conformation. So then we start giving people a drug like, thyroid.
Activated charcoal to improve their nutrient absorption. Sarcasm.
Ding, ding.
Ding, ding. Yeah. It's so funny. I don't use activated charcoal, although I produce a lot of charcoal from like when I'm using my green egg cooking. But,
Sure.
I don't do a lot of activated charcoal recommendations.
What would be your favorite things to like try to formulate into a, let's say, liposomal form, and then things you would say, let's not put that in the liposome.
Oh, sure.
We don't want people to absorb like 100 times as much of this.
Well, I think there's one thing where there's no sense in doing something like magnesium in a liposome because magnesium gets absorbed really well already, right? There's things that already absorb pretty well, so let's take those out of that mix. It's pretty, in general, you think of why were they developed? Why were solid state liposomes developed? They were developed because they would deliver opioids at a reduced dose, so you had less risk of toxicity and less risk of, mortality. And then also for chemotherapy drugs, in order to deliver drugs into the cell at a dramatically reduced concentration, so therefore reducing the side effects and all that. So in general, I think the question is, where are they of benefit? And they're a benefit on small molecules, which is another category versus peptides. So small molecules, peptides, very small particle size, that you're delivering. And then class 4 compounds, which are compounds that don't normally absorb very well. So things like glutathione, even though it's a peptide, it really doesn't absorb very well if you just eat a bunch of glutathione powder. It's not such a good thing, meaning you're not going to absorb much.
Yep.
Things like turmeric, berberine. Berberine 0.3% absorbed. If you just take berberine powder, 0.3% absorbed. Now, does it still work to kill off bad bugs and improve your zonulin in your gut? Yeah, because it's there locally and having a local effect.
Yep.
But it's not getting absorbed and then creating this other effect if you're just taking a bunch of berberine. Curcumin, lots of papers on curcumin being so variable. And in fact, we did a project with a group out of Germany. They had this nanotized water version of curcumin that you'd spray buccally. And they had a higher bioavailability than IV curcumin. And this was a medical company with, they had serious studies because in Germany, only physicians prescribe botanical medicines. You can't walk in to a store and buy a bunch of stuff. Like they take it very seriously. Botanical medicines. I was just I was literally just in Germany and was at an international garlic symposium there talking to physicians that were there. Even a claim you can make on garlic's got to be pretty heavily substantiated. They're very serious, right? So, from that standpoint, hey, what am I putting in there that I can absorb? The class 4 compounds are a great target because they provide a lot of value. But when we're doing intraperitoneal studies in mice, it's weird. Coming into the clinic, I didn't see a single mouse in the waiting room. It's so different, right? We can't, we don't treat them. So, getting them to absorb orally and be able to show it in humans is a whole different animal, right?
Mm-hmm.
So the class 4 compounds, great. Small molecules. So for example, a lot of peptides that they get destroyed in the gastrointestinal tract. If you can wrap them in a liposome and get them to absorb lymphatically and get them into your tissues quickly, you can see benefit, whereas in the past you'd have to inject them, right? So there's those kind of opportunities as well where, gastrointestinal destruction, you can bypass that. And I think any kind of drug, rapamycin would be a great example of if you could get less in, because I think that's one of those, it's one of our anti-aging great. I mean, one of my buddy wrote it. One of my best buddies, Ross Pelton. We wrote a lot of books together, databases together. Wrote a book on rapamycin, and he's in love with it, and that's cool. But I have concerns over rapamycin and absorption. Are you using Rapamycin? Are you getting a compounded one? Is the compounded one absorbing as well? Because we know it isn't.
Yeah, we've discussed, even in our practice, we've seen the commercial sirolimus product significantly different than whatever people get from these telemed clinics or websites, whatever you call them.
Some compounded rapamycins will peak at undetectable.
That's my point. Yeah. It's great that you guys are looking at that, because I think you should be looking at your sirolimus level. You should be looking at that if you're giving it, because that's a powerful drug. That's a no joke drug. When we're starting, that's the other piece. When we're starting to take drugs that, and this is kind of the law of hormesis, right? If you're familiar with the hormetic law in pharmacy, is low doses do one thing, high doses do another. Well, okay, what happens in all that gray area? Right? Is it all good up to when it goes bad, or is it kind of heading towards bad? Right? Once you're past the low dose. So that hormetic law is pretty important. And it's great that you're looking at that, because I have practitioners that I know I teach at, like as I said, at A4M, that it's like, oh, the compounder's making rapamycin. That's awesome. We're going to use that. And it's like, okay, but is it working? And are you measuring immune functionality? What are you looking at to say that, hey, that really worked to begin with?
Well, that's how you get your placebo group. You take the people that took compounded rapamycin for however many years. You take people that took Rapamycin, and then he's like, okay, what's the difference in these two groups?
Right. Well, it's interesting. We're doing a head-to-head. That's exactly right. Yeah. We're doing a head-to-head on Rapamycin and a liposomal tablet delivery to see if you can mimic it or not.
Okay.
Versus the
very cool.
Versus the branded, prescriptive compound.
Now that everolimus is generic, we could probably add that in. Its commercial price is going down pretty significantly.
Well, and that's the one that was studied for the immune, like you mentioned, measuring immune response,
benefit,
your response to a vaccine. Talking about vaccines a little bit, this is just a simple one. Like if you look at the high dose flu vaccine, there are some additional risks there. If you could give somebody everolimus and then have them take a regular flu vaccine,
it's studied.
It
for
would
that
be
reason,
basically harm reduction. If you're looking at, okay, we don't need to really crank up the immune system as much, because we can make the immune system work like it used to with this everolimus.
Yeah, and obviously with different pharmacogenomics, rapamycin is one of the ones that is more significantly different than everolimus. So there's, like you said, this is a complicated clinical problem that we do have time to work out for each N of one case study, which is what each patient should be. But most people that are on it just are not, they're not going to a clinic that does their due diligence, or perhaps they just get it from a website. So like you said, we share similar concerns over the adverse effects.
Well, it's hard when, it makes me crazy when people are buying peptides that are not for human or animal use.
Yeah, they heard on a podcast, so-and-so said that retatrutide is ready to go and ready for use and can easily and cheaply be purchased.
And you're like, well, what about the quality control there? And the quality control is, trust me, bro. And that's it. Relative to your
sometimes they'll have a random third-party test.
But it's not valid.
Yeah, works 100% of the time, 40% of the time, or something like that.
Well, obviously with my work at Peptide Society, I just came out with the second edition on the peptide handbook. We take it pretty serious that people need to know where they're getting what they're getting, because there's little things that could or could not happen. One of the things that you measure is endotoxin at the end of the production of a product.
Mm-hmm.
And if you're not don't have the same standards and methodology, you could end up with a lot more endotoxin in the injectable. And endotoxin is really bad.
Yeah.
Right. I mean, I'm just giving you really the one syllable, hey, endotoxin bad, because you can have anaphylaxis reaction. You can have dramatic inflammatory responses to injecting something that's high in endotoxin, and we've seen that when you look at the not for human use peptides, there's reduced dose,
mm-hmm.
excess dose. And when you're making it, you have to get rid of the kind of the intermediate steps. So adulterants could be there. There's a lot that could be there. And look, I blame, honestly, on this whole thing. So, all the FDA stuff that's gone on. I've been at the last couple of the pharmacy compounding FDA meetings. I actually went and attended and testified.
Thank you.
And
they just pulled a couple things off category 2.
Yeah.
So if you had a hand in that.
No, I don't think I don't know if I did or I didn't. I just know I went and I spoke my mind, and I was grateful that I got to go speak my mind.
Sure.
I think it's important, and everybody's working hard to get some of those back, because we need to get some of those back, right? But the point being is that, so the manufacturers of the active ingredient, the API, they're giving them to the compounding pharmacy. And what I got out of it was, well, the FDA didn't have as much problem with the compounding pharmacy's procedural piece. They had a problem with there wasn't adequate testing over here, but then the problem, meaning the manufacturer of the API. Yep. But the problem is that's the manufacturer the FDA approved. So they never gave them the guidance that was necessary to say you can release that lot because we're sure you followed the procedure that made it safe for a compounder to make it. Now I thought that, I kind of sat there at that meeting and I'm listening to all this going, wait a second. Aren't we supposed to ensure safety all the way through the chain of making a raw material?
You would think so.
Well, no, that was my thought. You would think that's what would happen, but that was one of the big things that I came out as a learning, is that there's still a lot more work that needs to be done on the safety on the API manufacturing. Active, pharmaceutical ingredient. API is active pharmaceutical ingredient.
I don't know how much of the information discussed at that meeting was confidential, but did they happen to discuss the country of origin for a lot of the raw material from those products as well?
Country of origin comes up without a doubt. And it's kind of interesting the way it happened, honestly, because when you go in, you've got a group of 20, FDA, and then you bring in their board of advisors. And one of the first things I see is there's a disconnect in that, and this isn't anything bad, but it's FDA saying, what disease does this treat? You don't have enough evidence to present. And then they will accept real world evidence, which that was another thing I learned, is that you could take a clinic that's using a lot of peptides. And if you can do age, gender, dose, outcome data, they listen to that. Mm-hmm. All right. So real world evidence was very interesting for me to understand that they accept that. It doesn't have to all be just a straight clinical trial. But then the issue becomes, because it's not for a disease, and this was kind of I got to make several statements. So the biggest thing when I got up, because I guess I got frustrated. To be honest, I kind of had this PowerPoint the first 2 times I was up talking. I'm talking through and it's like, it's not working. Third time I got up and I said, you know what, guys, I just got to be straight up with you. We got over 1 million prescriptions just on these 4 peptides. We went and I categorized 1 million prescriptions that were written and dispensed on 4 peptides. 1 million. And I said, that means there's medical providers writing prescriptions because they think this is helping their patient. And you're not connecting with this, first of all, this big issue that providers are using these. And and thinking it's helping their patients. So is it or is it not? Well, let's look at the data and figure that out. But the other one is you're not looking at these peptides for how they're actually being used. In general, unless you're looking at like ARA 290 for like a neuropathy or neural regeneration or diabetic neuropathy, or maybe metenkephalin for pain, most peptides are not used to treat acute illnesses in general. You may see something like Zadaxin for hepatitis. They're being used to keep people well. And we don't study how to keep people well. So there's a big difference and disconnect about a healthcare system that currently is just, hey, what diseases it treat? Do you have the data for the disease? Versus how does this maybe get applied to keep somebody well?
Yeah, MOTS-C is an interesting example because unfortunately there's probably no real world data on inborn heirs of like a maternal mitochondrial storage diseases.
Correct.
Which it should obviously be studied
Right.
in, but there is a lot of real world data on not.
Are you a fan of MOTS-C?
Not in general. It is one of the most interesting therapeutics for the future, but I do use it occasionally, but usually in, I guess, more extreme or aggressive circumstances. I do think that it is particularly interesting, but it does not have a ton of clinical data.
Right.
And I have prescribed it some, but it is not one of my go-tos.
Yeah, I think all the mitochondrial compounds, whether it's like SS31 or humanin or MOTS-C,
A lot of people use it for fat loss or weight loss, and I'm not too impressed with that. I'm more interested in, maybe the aging atrophic brain or someone who may have not been an athlete their whole life and has mitochondria more similar to a child's.
Yeah.
Or, of course, the easy use case, mitochondrial storage diseases.
Yeah, sure, absolutely. I mean, I think everybody's an interest of that now with, the whole COVID long haul / Lyme / SIRS or mold complexation people where they're getting a lot of mitochondrial uncoupling and aerobic glycolysis. So you're not making a lot of energy in your cell because you've either got inadequate amounts of mitochondria or dysfunctional mitochondria, right?
Those
and
are
I have to
cases
agree
where
with
I have
you.
used it. Yeah.
Yeah.
So,
yeah, that's where it might make sense, right?
Agreed.
But it's not. I couldn't agree with you more. People in general with peptides, I think, great, another tool in the toolkit that's really important. GLP-1s. I mean, look, for all the hysteria about GLP-1s, I laugh about it because I think, do we tell people not to take their insulin?
Yeah.
Insulin's a peptide. Do we tell them, oh, hey.
We tell them don't take too much insulin.
Right.
Don't take too much. Don't make too much.
Right. But so that's
real.
right on, though. Because a lot of, the whole role when you do need insulin is to have people take as little as possible through changes in lifestyle and what nutrients they need to make their insulin receptor work better, right? Or whatever it is, exercise, diet, lifestyle. But I think the GLP-1s are a great example of they can be utilized well. And I'm a big believer in them when they're utilized through titration of dosing while you're teaching them how to eat, while you're teaching them how to overcome their hedonic urge. So when they hit their goal weight and they get off, they don't just bounce right back to, mowing down 3 Frosties and a couple order of fries, right?
Yeah. You have to have both.
Yeah, you have to have both, right? And so I think it's, the peptide piece, I think I've seen some dramatic things. Like BPC is interesting, right? Where's all the human data?
I think there's one study out of a place
One
in
study
Florida.
from Florida.
Yeah. It was for like osteoarthritis.
Lots of
Looked like
anecdotal.
about most patients
real-world
found it
data.
useful, but you think about how many people have taken or been prescribed BPC, and at my experience, more than half of them are getting a positive outcome. They're like,
Yes.
I'm glad I took
Yeah.
this. Like a lot of positives, but it's not, I guess, funded through the typical FDA pipeline. So it's just a whole new model. It's not being built on ICD-10 codes and diagnoses and CPTs and these sorts of things.
That's why real world evidence is so important.
Mm-hmm.
Now, really, one of the reasons I built our cloud-based informatics platform was collecting that. Because for me, real world evidence is, well, what's everything they're on? Not just that you gave them BPC. Were they on an NSAID with the BPC? Are they on a PPI with the BPC? Are they on blood pressure medications with the BPC? Are they, what's all of it mean when you're doing it? And that real world evidence actually does carry weight if it is collected appropriately.
Mm-hmm. What percentage of people do you think have ever tried any sort of GLP-1? It could be exenatide, sure. 20 years ago for diabetes. It could be a sample. It could be a free test dose at their med spa.
Free test dose at the med spa.
It could be
it
could be them getting retatrutide from a research chemical website online. But,
right. Do you think they give, like when they do the sample free, do they like give them a big dose so they get really nauseous and they go, wow, this stuff really works?
Well,
it's a good question. Depends on if they know the difference between the dosing of semaglutide and tirzepatide, which they don't
not
always.
We've seen some 10x doses for sure. It's a common thing. There's actually,
that's why I'm bringing it up.
Lots of physician societies have said, "Hey, please stop doing this because we want to stop seeing nausea and vomiting cases in ER from first dose GLP-1s."
Well, I'll give you the number in a second, but I have one case where the woman thought that she would take it every day because she wanted to lose weight more. And she ended up in the hospital, with severe dehydration, like almost like a hyperemesis gravidarum, she's throwing up. She had, incredibly dehydrated. And they called me, wasn't from our facility, but they called me in just because of my, with the Peptide Society. And I said, they said, how long is this going to happen? How do I neutralize it? Probably try to give some Zofran or something, but guess what? Every dose has a 5-day half-life. So add it up, because that's that thing where people are microdosing, 4 or 5 times a week. I'm just doing a little every day, they don't realize there's a 5-day half-life to this stuff. How many people have ever taken a GLP-1? Well, 50% of the population is either insulin resistant or diabetic in the U.S.
Or overweight.
And then we add overweight.
About 150 million.
Yeah.
Of the population.
That's a big number.
I'm gonna say that you're probably at 40%.
Yeah, that's exactly what we thought. This gave us a good algorithm boost in the comments last time. We said almost half
which
have
is
tried
is
one
crazy.
once.
The point you made was like, if you would have asked 5 years ago, the average person's like, hey, you know how to do a subcutaneous injection just off the street? They would say, what's that? But now everyone's like, oh, is that like the pin? Or is that like what I get at my med spa? They know what it is now.
Yeah, they do. Well, what's, I don't know. It's scary. You go into some Facebook groups and you have some woman posting, there's a needle there, a tuberculin needle or insulin gauge, and her question is this the right amount?
Yeah.
Frequently.
Happens all the time. They don't know the concentration.
And if they haven't had I worry because do they have a low-grade pancreatitis? Because if they're already insulin resistant and 40, and look, I'm going to be very transparent here. My brother at one point was 476 pounds. I love people of all sizes. I want to help people of all sizes.
Mm-hmm.
I'm just being straight up. I have I think it's one of the things, I have a real passion to try to help people lose weight because of it. Because I grew up around him in that struggle. But if she's 50, 60, 70 pounds overweight, she very well could have a low-grade pancreatitis. And that means that she's going to be like, am I doing the right amount? It's 10 times higher than it should be or 5 times higher than it should be. And that goes back to that point of, could we stop doing this? Because the docs, the just kind of more traditional docs are having to field all these issues.
They're on the front lines.
Yeah, because there's no filtering of it, and you're buying it online, and you're buying it through a research-based pharmacy. What I do know about America, and I hope it's what we apply to let's get healthy again, is whatever's worth doing. No, we just came from Texas this morning. Whatever's worth doing is worth overdoing. So let's overdo the healthy stuff, right? Not just look for the magic bullet. I do like to dispel some of the myths on GLP-1s. Like people say that you lose muscle mass because of the GLP-1. all the clinical studies say that it actually helps to reverse the signaling of people that are diabetic that are upregulating FOXO1, which is causing more what I call fattening of your muscle. You're becoming A5 Wagyu instead of, staying horse meat, right?
Yeah.
I mean,
diabetic cows taste amazing.
Yeah, that is true.
Now do you stick their hoof before you decide? I mean, I'm just trying to
give me
wonder
the cow with the highest A1C. That's what I want.
Yeah. I do think that's a great myth to dispel. At the same time, obviously, if you're on a GLP-1, you should be resistance training, getting adequate protein, and not be on such a high dose that your appetite is over suppressed. Because very low calorie diets, VLCDs, have the same potential for muscle loss.
Identical data, right? 30 to 40% muscle loss if you're doing a medical weight loss or a GLP-1 induced weight loss. And that's because if you're not getting enough calories, it's bad. Well, we're using GLP-1s as a part of what we do at Lifetime in our Meora centers. We have longevity centers there, but we have a medical director, nurse practitioner, dietitian, strength coaches, and we do exactly what you just said. We get them training, making sure they know the amount of exercise they need to do. We give them protein targets. They have to check in with us. And we titrate the dose to where we get them to where, hey, you know what? Once you're losing 2 pounds a week, why don't we stick at that dose? And then that way, when you go to get off, you don't have this tremendous receptor deficit when you no longer have the drug on board, right? Because when you're giving these big doses, the incretin hormone receptors are just, like, hey, they're dependent on that big dose of drug versus what I'd say cajoling it back to functionality by proper diet and exercise. And I think if you don't get enough calories, yes, you're going to lose fat. Now, I saw some study published yesterday that somehow was shrinking the heart. I didn't get to read the study yet. The shrinking heart muscle. I was like, well, was that in diabetic and pre-diabetic people that already had enlarged hearts?
Chronic hypertension for years
with hypertrophic cardiomyopathy.
Right. That's what I'm talking about. So it shrunk. Yeah. Cool. So, but obviously nobody goes that far to think through that, unfortunately. But I think that it's a big myth. It's like, look, you do not have to lose a lot of lean mass.
What do you think about all of these influencers and public people that have, their normal body fat percentages? Maybe they have a slightly elevated BMI. A lot of us that have more muscle mass do.
Sure.
But it seems like they're looking for an excuse to be a little bit more shredded. And they're like, well, no, I'm microdosing this because of my brain or X excuse.
Yeah. I'm protecting my kidneys.
Yeah. They obviously don't need an excuse if they want to do something, but shouldn't they be accurately conveying the risk-benefit profile in whatever they're actually doing this for?
Oh, I couldn't agree with you more on that. I mean, I think, if you don't need to be on a GLP-1, and I think BMI is obviously it's a slippery slope. You get depending on how muscled someone is, I have a BMI, I think, of 31. I don't think I look particularly overweight. You guys look like your BMIs are probably skewed. And so let's look at percent body fat. Let's look at visceral fat. I love it if we can do, whether you're doing body comp, however you're doing it, something accurate, hopefully, that we base things based on that. Do you have a bunch of visceral fat to lose? What is your percent body fat? How much are you over your ideal weight when you look at you and you go, oh, well, you got pretty much hanging over that waistline there. Yeah, we could probably think about using a GLP-1 on you.
My lowest ab cut is not as defined as I would like it to be.
Yeah.
But if I took a GLP-1, it would be to help my brain health, even though my fasting insulin's never over 3.0.
You have absolutely reconciled with yourself the rationality of doing a GLP-1, haven't you? That's great. I was thinking you looked a little leaner this time than the last time I got interviewed. I was thinking you guys.
I think that was the beard. Yeah.
Yeah.
Maybe that did
no,
it.
I have not done, I've not started a GLP-1. I have lost over 10 pounds in the past several months training for high rocks. I've set some, not lifetime, but recent 5K PRs. Cool. And I've done some high roxes with my friends from Lifetime, actually.
Right.
Did not need a GLP-1 in order to do that.
See, I think, so let's I want to tear this apart a little bit more because you brought up some great points. One is if you're willing to work hard enough, less people would need GLP-1s. If you're willing to eat better and exercise more, and the younger you are, I think the need goes down. So motivation's big. I think the indications are the indications, right? You get into a slippery slope when you start going, I want to think just a little bit sharper. So I'm going to go to 60 milligrams of Adderall, and I'm going to do it intranasally by grinding it up. Right? I mean, there's just that thought process of, taking a very powerful pharmaceutical agent, and then I get it. We want to try to optimize our human body, but is there any physiology that's there that supports that, or is it just you want to shred that last 16th inch off? And I would say that there's probably other things that you could use. There's small molecules that are very interesting. There's, tesofensin is an interesting compound. Might raise your heart rate a little bit, but I mean, it's a really interesting compound for pure free fatty acid mobilization and burning fat, right? So I just think, GLP-1s, let's use them for people that really need them. And then once you're getting to the point of being dialed in, maybe be a little more disciplined like yourself. You took 10 pounds off, training a little harder, it sounds like, and maybe you were more diligent or changed your diet. I don't know. I mean,
less weightlifting. Yeah. More children and newborns and less sleep.
More children, less sleep. You know what?
This is calories.
It helps me take the weight off.
Perfect. Well, it brings up the point of, how much weight training is good weight training, because there's two camps on that as well, right? And what I learned is I want to, it's all about how big you want to be, and how much, where are you at in terms of your balance between strength training? Because there is, if you look at like microcapillary flow, so if you look at Hans Vink's work and the microcapillary camera that they use to measure microcapillary blood flow, and he was the one that discovered the glycocalyx, the inner lining of the artery, right? Yep. People that are heavily muscled and really push hard and create a lot of compression in that muscle, a lot of times are damaging those microcapillaries. So I think, there's all that stuff gets into, am I creating micro metabolic inflammation by overdoing that strength training and therefore can't get to that last bit of fat?
It's interesting because the capillarization of the muscle also is a predictor of hypertrophy. So people are like, oh no, I don't do cardio. It's going to steal my gains. That used to be the thing in the bodybuilding space. It's like, no, you don't do cardio. You want to be small. Yeah. Get out of here. So it's really interesting. And that was, me, 16 years old. I'm like, cardio? No, not going to do that. But now is like more and more data has come out, VO2 max, aerobic fitness, and these things, and healthy aging, which is the goal for, I think, all of us sitting here.
Sure.
It becomes really compelling. Yeah. And I really agree with your approach on like, someone who's just looking to lean out a little bit. Maybe they want to go from 15% to 12% body fat. It's like, you don't have to use the sledgehammer to get the job done. Like they're like, I want tirzepatide. It's like, well, the more dialed in you are, the worse your risk reward profile is with the sledgehammer.
Right on.
Whereas if your A1C is 12, it's like, we need 2 sledgehammers. Like let's get you.
Jackhammer.
Jackhammer. Yeah. So I think it's really interesting. And I have an idea of like the drug companies are all pushing for like how much weight loss can we get in a year or 72 weeks or what it is.
Sure.
And, that's what's going to pump the stock prices. And I get it. It's a business. And if you have someone lose, maybe they get to 40%. Like that's going to start to have some downsides like you're talking about on the muscle side, because you don't need to lose 40% in a year. You don't need to lose 25% in a year. But they want the fast results, the big numbers on the scale. Whereas what you're building out with Lifetime and sort of the way we practice it is it's more sustainable. People make progress for a longer period of time. They don't stall out.
Right.
So you can start with something milder, and then you can graduate to something if you need a higher ceiling effect. You don't always have to start with the strongest compound.
Yeah, no, agreed completely. I mean, even our certification course that we teach at the American Academy of Anti-Aging Medicine on GLPs, it's all based around this thought process of the gentlest notion to get the body to lose fat, not lose muscle. Muscle's a super important currency for our aging process, right? We want to keep muscle as we can. I love like my new darling's OSO1. It's a small molecule that modulates mTOR, upregulates AMP kinase, induces autophagy. So you get kind of a build lean, lose fat, and you can modulate it because you can pulse dose it. So there's other compounds out there like that. I think people need to look to. They just don't have to think about it's all about semaglutide, retatrutide, and tirzepatide. And I do concur. I worry about the rapid weight loss on a lot of levels. Like, when you're losing 30% of your muscle mass, right? To your point on that equivalent low calorie diet. Well, you're not getting that back. And what happens when you gain that weight back and it's mainly fat? And then you go again. This is no different than the old famous HCG diet. That I had my fourth year med students. We did a white paper. I had them do a placebo group and then do an HCG diet group, where we saw this benefit. But then there's the rebound effect of, rebound ghrelin because you're under 500 calories or at 500 calories a day. And
speaking not a sustainable diet.
Speaking of losing more than 30% of your muscle mass in a month or two, let's say you tore your pec a month or two ago, like James. We've been discussing this a lot.
Yeah.
So obviously you want to gain your muscle mass back, and we've discussed your stack and whatever peptides that you've considered or taken. But
what are you doing?
Yeah, I'm happy to lay out the protocol. It's interesting. So I tore the pec. Let's see. I guess it's been
almost 2 months?
Over 2 months now. Got it put back together about 6 weeks ago. Out of the sling, doing PT. Flat bench press, which is frustrating for me because I'm not a big flat bench press guy. I've never been like an ego lifter.
Yeah, right.
But at Lifetime, they're
too busy.
They're suffering
Friday
from
afternoon.
success, right? They're busy. So I was like, well, instead of doing like the incline dumbbell, I'll go lighter. I'll do flat today. So I was doing
light for you.
Yeah, 245, which I can get for probably 8 because I haven't done flat in a long time. Doing sets of 4, the third set in. Right here, I just felt it was the third rep, and I felt like this pinching and cramping and like electrical pain. I was like, oh,
yeah, all that.
I know what happened. So I can get the weight off me because it's not that heavy. I sit up, drop the weight. Nice guy comes over. He's like, hey, let me help you re-rack this. And I was like, I just tore my pec. I was like, I think we're going to have to take the plates off this thing to re-rack it. But nice of people to come over. Lifetime's a good community like that.
Right.
So that's the injury. And then got my MRI, had my surgery. We're actually going to have the surgeon on the podcast at some point.
Oh, yeah, very cool.
Talk with him a little bit about the repair.
Right.
Tore it at the myotendinous versus off the bone, which is a little more tricky. Another reason to chat with this guy.
Mm-hmm.
So what I'm doing is BPC 157, TB, not TB4, but TB 500, which is what you have now.
You call it TB4 frag.
Yeah.
Has the mustache and glasses on.
Yeah. Those, a lot of the same things. So I'm doing the TB at 2 milligrams twice per week, the BPC at 500 micrograms daily, both injections. So not too bad as far as being a pincushion. It's a 60-day roughly course that I'm doing.
Kind of light.
Yep.
And then the hormonal side of things is really interesting. So
sure.
I don't know if you're intimately familiar with like Peter Attia's podcast and those sorts of things. Mm-hmm. So he had a shoulder surgery.
Right.
And he ran a course. I say a course. He tried some nandrolone and
HGH.
Yeah, and HGH afterwards. I'm not doing anything with the GH side of things just because I've probably done 2 or 3 shots of a GHRP before. I tweaked something. I was like, I'll try this. Actually made my sleep objectively and subjectively worse. So I was like, all right. IGF-1 is pretty good. It's like 200, 250, kind of in that range.
So I don't want any higher than that.
Yeah. So I was like, I'll heal up. I just want to make sure I'm sleeping well, like after surgery.
Right.
And then the nandrolone. So this is what Peter Attia was taking. And I've been on testosterone replacement for a long time. So I did my washout, let the testosterone clear my system because I don't want both of those in there necessarily. And I think that's where people get into trouble when I see people that have come in on nandrolone plus testosterone. They don't seem to play nicely together.
DHT goes through the roof. You get all kinds of. Yeah.
So I've got just the nandrolone. And then because it doesn't aromatize well, I've got a little bit of injectable estradiol alongside that, which Amazon Pharmacy is always trying to get me to refill. No clue why. But they're like, hey, your estradiol is ready. You should fill this again. I was like, that vial is going to last me 10 years. What are you talking about? So
they want to make you a better shopper.
Yeah. That's funny. Yeah. So that's my recovery protocol. I didn't pull the plug after 2 weeks. Peter Attia tends to really analyze things.
Blood pressure went up or
One
something
of the
like
things
that.
I really
What was
like,
the dose you used?
100 milligrams a week.
Yeah.
So it's split 50-50.
Yeah.
The estradiol, I think, is it's just shy of 1 milligram per week. So it's a very low injectable dose just to get my estradiol up. Landed
you need it for the connective tissue
Yeah.
healing at the juncture, sure.
Yeah. So it landed around 40 on a LC-MS assay.
Right.
Like, okay, that's reasonable.
That's not bad.
So yeah, Peter Attia is really good at analyzing things, but I think he overanalyzes. So he was like, had his surgery, blood pressure was up, blood sugar was up, wasn't sleeping well, and he's like, it's got to be the nandrolone. So he
likely the GH.
dropped that.
100%.
Which is a really long-acting androgen, right? It's not like, so he basically just shut down his testosterone production post-surgery. So I'm going to stick it out. I'm just going to do 12 weeks, let it wash out, go back over to the testosterone side of things. I mean, as far as flexibility, things are going really well as far as PT. Would I have healed up fine anyway? I don't know, but if there's an edge there and like my safety profile is reasonable, I haven't had any blood pressure changes. My lipids are actually better on this protocol, probably from the estrogen, I'm thinking.
Yeah, most likely.
It's been really interesting. So we're going to do sort of a case series, talk about it on the podcast a bit more.
Yeah, I like that. And I mean, it's unfortunate nandrolone is kind of looked at in such a negative way because, I mean, low dose nandrolone in aging men, 55 plus men, I mean, man, helps keep their tissue metabolism on point. You get a lot of anabolic drive, a lot of nitrogen retention. There's a lot of positives to it. The only you got to watch is that you get some men in the subset where the DHT goes up, and sometimes that's in those men that are, like you said, crossover with they're still on test and they do nandrolone.
RAS dysregulation as well is more likely with it.
Right. So then I know for me, I remember when I had a common extensor ligament surgery. It took about 8 hours to repair because I had some apparently tissue donor activity that had to be done, and just from my heavy benching. Were you warmed up before you racked that 245 up there?
Yeah, it was not like the first
James
set.
Really
it was my third set in, and I'm the guy that doesn't do CrossFit. It's like those guys are going to get hurt. That's not for me. I mean my training volume wise, so I had a couple of factors. Like I've had a first degree relative tendon rupture. Took statins for about 5 years. There's a lot of case series there. I don't think that's 100% of it, but it's a few percent maybe. And I had compartment syndrome where I broke both of these bones. So thinking like biomechanically, the sides probably aren't perfectly balanced. Right. But I mean, 5 years ago, I was
doing yoga.
Doing yoga. I'm too stressed out.
Stop the weights.
Yeah.
Stop the weights.
Yeah. So no, I'm not going to retire from lifting. I'm going to
of course
get back to it.
No, it's so good. So good for you, right?
Yeah, and I
there's
think
many benefits.
The injury in the short term is like, it's nothing if I'm looking at the timeline, right? Trying to make it to that healthy, vibrant 85. It's like, I mean, getting hurt working out is a bummer, but it beats the alternative.
Yeah, and I think there's certainly merit to understanding that you were doing a different movement. So
that's what I was.
If you do relatively routine barbell benching, then you're probably not going to have as likely of an injury, but I do think it was particularly bad luck because you generally are very careful. Kind of the same thing when people start alpha classes or CrossFit, especially that are really strong. The stronger they are, the longer you have to let your tendons and ligaments adapt to that new style functional fitness training or whatever it is.
Absolutely. That's a big issue. It was funny. I was, working with somebody, we were on a project together and he was on an anabolic cycle. We put about 25 pounds on in 8 weeks, which is all going great. But he tore his Achilles. Well, of course he tore his Achilles. You put too much muscle on for your tendons, You can't, your tendon strength wasn't there yet. You had all that muscle to drive it and you didn't condition your tendons enough, right? So it's interesting. I think my biggest thing is just getting people back to moving. An interesting statistic, since you guys like statistics. This is a good one. If you're on a GLP-1, you're 2 times more likely to go back in the gym because you start to lose weight and you feel better about yourself and you don't have as much shame.
Yeah.
It's kind of interesting, right?
It is interesting.
Yeah. I mean, just in general, right? Because I think that was the other piece is that a lot of people, They do everything we say. They eat right. They exercise. Maybe they haven't taken things. They haven't got a full evaluation and you put them on a full thoughtful program. But maybe they ate right and exercised. They didn't lose a pound after 12 weeks.
Yeah.
That to me is that misunderstanding of what's going on with their chemistry. And that's why, you do a GLP-1, which maybe it's like what I call a Band-Aid on a bullet hole, right? There's a lot going on why that GLP-1's, why it was so desperately needed. But it's really all about that fact that, okay, I see a little success.
Yeah.
There's hope. There's hope.
Spouses that do it together also tend to do better in my experience.
Right.
Maddie and I have talked about this, whether it's smoking cessation or going to the gym.
Right.
It's good to have things in common with your family other than you like raise kids together, if that makes sense.
Right.
Because at some point, Maddie and I thought, wow, we used to have all these things in common, and now we raise kids together and we go to the gym and we both do like alpha classes and CrossFit competitions. And I guess we garden together and cook too, but
it's getting pretty similar now. That's
good. I mean, certainly as we age, I can see that a lot of males and females kind of have less and less in common. And I think it's good accountability to have gym friends that are outside, maybe your church friends or your neighborhood friends.
Right.
Because those friends are not going to keep you accountable to be consistent with your exercise.
Yep.
But if you don't show up to a bunch of Aurora or alpha classes or whatnot, then those people will say, hey, what's going on? You need to get back here.
Yeah, no, I couldn't agree more. I mean, I think it's important that once again, it goes back to that lifestyle. So, I've been married, 26 years. My wife's a dietitian, former ballerina, gets the value of good diet, gets the value of movement, gets the value of cooking fresh, all those things. And then we enjoy, other aspects of it. But what's a little different is she's not much on weights. I really like my gym in my house. I mean, I got it because I'm like 20 minutes from the closest Lifetime. So I'll go there because I need to go there. I need to show up. And I'm also in Minneapolis really often. But, in general, it's like, I've got my first generation Nautilus pullover and I got a pretty good gym in my garage. And I'll spend a lot of time out there, and that's not as much her gig, but we still are kind of holding each other accountable to age gracefully, right? That's kind of where you want to be. It gets back to that whole concept of you want to develop a lifestyle that's promoting that longevity. And when you don't do that, it just becomes a series of unorganized tasks. I'm going to get in the sauna today.
Mm-hmm. Yeah.
I'm going to stop and get donuts.
Proactive rather than reactive. Like you think about, what am I doing to be healthy? Not how did I get to be X, pounds or X% body fat, or, what happened? Yeah. Why are my knees hurting? You got to think about being proactive there.
Yeah, I think that's some sage advice to perhaps wrap things up with. But,
sure.
We do like to ask people if there's a specific spot that you would say, if you're looking for high yield, good information, whether it's scientific or clinical information, where they can seek you out more or seek more sage advice.
Sure. The Real Jim Lavalle. My Instagram, I mean, I like to think we post pretty solid information on that. We go through studies and, plenty of interviews. So that's a good one. JimLavalle.com is a good one. Those are probably two real great spots. And then there's, 26 books, soon to be 30 with the second reprints, and 5 databases and a couple hundred articles. If they research me, they can find a lot of information. Passionate about giving out good information.
Wonderful. Well, thank you again. As always, thank you to the audience for their time listening. Hopefully they understood all the different sarcasm episodes that all of us had.
The counter is going to be the record, maybe.
Yeah, lots of sarcasm counter. But that's a good thing, I think. We had a lot of fun, of course. And it's fantastic to have you as a guest. I think this will be lots of good follow-up questions and interaction. So please post your comments, whether it's Instagram or YouTube or Spotify, whatever. Please put nice, mean, and in between comments, because it's all good for the algorithm. So, yeah.
No, that's great. Well, thanks for having me. I mean, this is, I really appreciate that when I see young, and all kidding aside, young professionals in this healthcare space, taking such a serious look at, how we're going to help people to age better and create wellness for them. It's nice to see. So really appreciative.
Likewise.
Thank
yeah,
you.
we appreciate it. And thank you to the audience for their time, and may God bless you with health and happiness.